So we have to talk about the WHI, the Women's Health Initiative. So I'll let you start the conversation off by talking about maybe some of the shortcomings in terms of population selection for the WHI, so who was included in the study, and then some of the different arms that they looked at in the study, so the estrogen only arm, and then the type of interventions that were used and why those are a little bit different, very different than the hormonal interventions typically offered to patients today.
Of course. I always say this, that the pink elephant in the room is that, the vast majority of women and doctors are making their hormone therapy decisions based on fear and, misconceptions. And the fear of breast cancer is largely driving women's access and decision making, as well as doctors. And that's all because of the Women's Health Initiative, which was a very important study. We're not about to throw the baby out with the bathwater. We learned a lot of good things, important things from the Women's Health Initiative, which was the largest to date study ever done on hormone therapy in women. But there are huge problems with the way the results of that study were messaged to the general public as well as to the physician community back in 2002. And that has left a legacy of fear and misinformation that has left a generation of women and doctors feeling really uncomfortable and nervous about using hormone therapy, primarily because the message that went out, kind of the soundbite, was that estrogen causes breast cancer and it also caused all these heart problems. So it's dangerous. You should only use it if you absolutely have to. And because of that message, physicians who were in training at that time, I was a second year OBGYN resident at the time, really just didn't get any education on actually the science of hormone therapy. And there was already a lack of education on the physiology of menopause in general. And that was like the nail in the coffin. There was just literally no interest in really pursuing them. So here we are now, fast forward over 20 years later, right? Where just a generation of doctors and women are misinformed. But here's the facts about the WHI study that are really important for women to understand. First of all, it was already established that estrogen and hormone therapy was FDA approved for the treatment of hot flashes and night sweats, so vasomotor symptoms, lowered the risk of osteoporosis. We knew it treats the genitourinary syndrome of menopause and, was also used for women who went through menopause early. And it had been well established and, used for decades, right? It was one of the most commonly prescribed medications. The interest arose because there was a lot of data, a lot of observational data showing that hormone therapy may be also protective from the cardiovascular system. And so they wanted to test that hypothesis. So essentially, the WHI study was not whether hormone therapy was safe or not. It was already determined to be safe. It was whether this would be something that we can use for primary prevention for heart disease. So it was really, that was the primary outcome that they were looking at. And so in order to get that outcome and, and get some meaningful results, they had to recruit older women. Right. And they had to recruit women who no longer had hot flashes or night sweats, because otherwise they would know whether they were on the hormone therapy. Right. Because otherwise it couldn't be placebo controlled, because you would know if you were getting the hormones if your hot flashes went away. So it's important to keep that in mind. The population of the WHI was, in general, an older population than the average woman seeking menopause therapy, which is women in the late perimenopause stage and normally women within the first 5, certainly 10 years from, menopause. That's the average kind of woman who's seeking it now, right? So these were older women, and on whole, they were, they did have elevated cholesterol and elevated blood pressure. They were older, they were less healthy, right? But even with this older population, and we should say they separated these women in 2 arms. If you had a uterus, you took an estrogen plus a progestin. And if you didn't have a uterus, you didn't have to use a progestin, so you used estrogen alone. And fast forward, they stopped the study short and they held a big press conference that said it causes breast cancer and there was an elevated risk of cardiovascular disease. And that went out like a lightning rod to the world. Everybody got scared. But the facts are that the women in the estrogen only arm of the study, never showed an increased risk of breast cancer. At that initial press conference in 2002 and on subsequent follow-up. And at the 20-year mark, they were found to have a lower risk of ever getting breast cancer by roughly about 23%. and up to a 30% decreased risk of dying of breast cancer. Okay, so let that sink in. The estrogen only arm, no increase, actually a lower risk of dying of breast cancer. Estrogen only arm. The progestin only arm, those women had the other arm was estrogen and a progestin, and that arm of the study showed a slight increase, statistically not significant, reaching statistical, not quite reaching statistical significance, but they reported it as though it was statistically significant. But let's just take them at face value and say we even believe that it was actually an increased risk. The increase was an increase in incidence of breast cancer, okay? And it was less than one additional breast cancer for every 1,000 women taking it, right? And on the 20-year follow-up, it showed there was no increased risk of dying of breast cancer. And that increased risk was similar to modifiable lifestyle risks like having obesity or, drinking, excessive alcohol intake, right? And so that is really not the message that was sent out to the public. The message was that estrogen causes breast cancer, right? And that is not what the WHI study found. And in fact, the WHI primary investigators have now walked back all of their original claims. And, they say like we should never use the WHI to withhold menopausal hormone therapy access to women out of fear of breast cancer. But old habits die hard. And, so that's kind of the background. If you want to learn more about this, the best thing you could do is pick up the book Estrogen Matters by Carol Tavris and Evelyn Blooming. And that really explains it in detail for the layperson out there or the doctor out there who's kind of confused by all this kind of different arms of the study. And that really puts it in clear perspective. And then, alluding to what you alluded to, the different formulations. And so it's important to remember in the WHI study, they used conjugated equine estrogen, all right? That's Premarin, and they used a synthetic progestin, medroxyprogesterone acetate. And remember, we should not fear conjugated equine estrogen. And I know for a variety of reasons, which we can talk about, these days we prefer really FDA-approved bioidentical estradiol. That's what we generally prescribe in hormone therapy. But conjugated equine estrogen is frankly the only estrogen that's been studied in such a large study like the WHI that actually showed a significant decrease in getting breast cancer or dying of breast cancer. So we should not fear conjugated equine estrogen when it comes to breast cancer risk. And we shouldn't fear estradiol because neither have ever shown to cause or increase your risk of breast cancer. Now, the medroxyprogesterone acetate was an old synthetic, progestin that is still used and is useful in very specific cases. It can thin out the lining of the uterus well, can help control bleeding. So we use it for specific things. But in general, we don't use medroxyprogesterone acetate in hormone therapy anymore. And in fact, we now use bioidentical FDA-approved progesterone in the vast majority of cases, or one of the other synthetic progestins. And when we compare those progestins, we see that medroxyprogesterone is probably the least beneficial on breast tissue, right? There's more inflammatory response to it. There's other aspects of medroxyprogesterone acetate that are, kind of less ideal on breast tissue. So I always like to come back. What is the worst case scenario in terms of risk? If I prescribed you a combined, basically what Prempro, is the conjugated equine estrogen with a synthetic progestin. What does the data tell us? It tells us that even with that old school formulation, your risk of breast cancer incident appears to be similar to modifiable risks like I mentioned, like alcohol intake or, unhealthy lifestyle or, having obesity, right? And that risk is less than one additional person for every 1,000 women taking it. And we must weigh that against the many benefits of hormone therapy, including prevention of osteoporosis, right? 1 in 2 women will suffer a fracture in their lifetime, right? And we can get into those details. Symptom relief, quality, of life, better sleep, all of these things, right? So you're more than just your breasts. That's the other thing to, remember. And then the last thing that gets a little bit into the weeds, but, there is serious criticism of even that risk associated with the synthetic progestin. Dr. Avram Blooming published an incredible piece along with colleagues, and many other leaders in this space have deeply criticized how the WHI interpreted their own statistics and that it didn't actually reach statistical significance. So that's why I say worst case scenario, if we even believe them at face value, it's still such an incredibly low risk. And we can modify that by choosing to use progesterone and, and really looking at the full picture of the woman, right?
Beautiful. Beautifully said.